Good afternoon, everyone, again. The focus for today's topic is I'll be talking about medullary thyroid carcinoma with some focus on the recent topics that have been the focus of research. So we all know that MTC accounts only for about less than 5% of all thyroid cancers, but about 15% of total deaths that are attributable to thyroid cancer are because of MTC. It arises from parafollicular C cells, and it's a relatively aggressive type compared to other well-differentiated follicular thyroid cancers. So at presentation of these patients of MTC, about 50% of them are seen to have localized disease, 35% may have locally advanced, and about 13 to 15% can present with distant metastasis. Okay. So the stage and age of the diagnosis are very important prognostic factors, and early detection and diagnosis of the tumor are therefore very important for its cure. So the special aspect about MTC is its familial form and the known genetic mutations, which we will see in detail. About 75% occur in sporadic form and about 25 to 30% occur in familial form. And mutations in red proto-oncogene are central to the development of MTC. So the recent studies have also shown that there are many microRNA and epigenetic changes that are also contributing for the development of MTC, which are the focus of investigation these days. More than 60% of patients with sporadic MTC have somatic mutations of red gene, and virtually all. Yeah, thank you. So virtually all, that is about 95 to 97% patients of hereditary MTC have germline mutations in red gene. More than 60% of patients with sporadic MTC have somatic mutations in the red gene. About 18 to 80% of sporadic MTCs which lack red mutations are seen to have somatic mutations in the RAS group of genes. It is mandatory at this day and age to test for red mutation in any patient of medullary thyroid cancer, whereas if there is no MTC in a sporadic, if there is no red mutation in a sporadic MTC, it's not mandatory to test for RAS mutations because the implications are not as robust. So briefly regarding the cell of origin of MTC, the C cells previously thought to be of neuroendocrine origin, based on current embryological studies, extensive studies have shown that they are of endodermin origin. So C cells are most numerous in the upper 2/3 of the gland, especially in the postromedial aspect of the thyroid lobes. So can I ask, I mean, anyone can volunteer to answer this. Why is medullary thyroid cancer called as medullary? Okay, maybe you can keep thinking over and we'll talk about it at the end of the talk. So the normal C cells produce calcitonin and procalcitonin. Procalcitonin is the precursor and it is modified into calcitonin. Whereas CEA, the carcinoembryonic antigen, which is one of the prognostic factors, is produced only from the malignant C cells, but not from normal C cells. So all these three molecules are important in the diagnosis and prognosis of MTC. So as we can see in this picture, these are all follicles filled with colloid, and these are parafollicular cells. So that though they are called as parafollicular cells, they may be interfollicular, intrafollicular also in location based on the most recent literature. So the interesting aspect is there is a pathological continuum in the development of MTC from C cell hyperplasia, where we have window of opportunity for cure, then develops probably micro MTC, then MTC, of course, then lymph nodal or systemic metastasis can develop. So when do we call C cell hyperplasia on a specimen? So the definition is that more than or equal to 50 calcitonin immunostained cells observed for 3 power fields of 100 times magnification. It can be either neoplastic or non-neoplastic. So basic difference is presence of atypical C cells. So if there are atypical C cells, then they are classified as neoplastic. If there are no atypia, then they are classified as non-neoplastic types. Non-neoplastic can be focal, diffuse, or nodular. Irrespective of whether it is diffuse, nodular, if there are atypia, it is called as neoplastic T-cell hyperplasia. So we have a beautiful publication from SGPJ that I've quoted here. You can all go through it. And so how is the workflow different in MTC compared to other thyroid cancers? Is that in addition to the routine biochemical TSH part, we have to additionally do serum calcitonin and serum CA estimation, and genetic testing and testing for other components of MEN2. These are very, very important in MTC. So am I audible? Is it?
Yes, ma'am, audible.
Okay, thank you. So let us see how the serum calcitonin and CEA are important. So calcitonin is a biomarker. As I mentioned, it is derived from procalcitonin. Earlier, the assays were very unreliable because they were estimating even the macromolecules of procalcitonin and polymers also. But the current latest bioassays that use immunochemiluminescence, that is very important because that is one of the questions asked during Viva, use sandwich technique with 2 antibodies, and they are bioassays. They assay only mature calcitonin products, but not procalcitonin, and only the functional monomers. And it is important that a particular patient be evaluated from the same lab because there are wide variations in the standardizations between the labs. So interpretation of calcitonin report is very, very important, and we have to be aware. So again, there are large population variations in the levels of calcitonin. The normal reference range is less than 10, and more than 10 is supposed to be abnormal, but one has to keep in mind the normal variations, the gender, age, BMI related variations also. Not only that, there could be laboratory artifacts, there could be other drugs interfering and causing falsely elevated calcitonin despite not having MTC. And there are pathological conditions which are neoplastic as well as non-neoplastic, like the chronic renal failure, autoimmune thyroiditis, sepsis, pancreatitis, and hypergastrinemia. All these and other cancers like breast cancer, small cell lung cancer can also have elevated calcitonin. So I have included stimulated calcitonin testing because it can be asked in the exam, but we don't perform it as much these days. So this was important back in the days when it was important to detect calcitonin early before genetic testing was there to decide when to operate or not. So first pentagastrin was used, but nowadays, even if we have to do, we use calcium gluconate stimulation. And cutoffs are as mentioned here, 130 to 540 is positive in males and females. So as we can see, the in females, the levels of calcitonin is much lower. So the importance of calcitonin comes in the preoperative workup of MTC, screening for familial disease. It's a preoperative prognostic marker. Some of the groups, like from Germany, Dr. Drale and Andrea Mackens, they have studied the levels of calcitonin and have correlated with the extent of disease and as a guidance for the extent of surgery, as I will describe later. And it's a postoperative marker to indicate cure, persistence, or relapse. And doubling time of calcitonin along with the CEA doubling time is used to prognosticate MTC given patient. As we can see here, if the doubling time is less than 6 months, only in years, whereas if it is more than 2 years, nearly almost everyone survives at 10 years. I mean, indirectly from this, we can also see that MTC, though it is an aggressive type of thyroid cancer, the rate of growth is quite slow. So when I'm saying that the doubling time is more than 2 years, even almost 100% live up to 10 years, means that the rate of growth in most of the tumors is slower compared to other cancers in general. So calcitonin and CA measurement for the assessment of treatment response, especially for systemic therapy in metastatic cases. So pitfalls in calcitonin estimation. This is, I know, that favorite question of some of the examiners that probably you will face. Heterophile antibodies interfere in its estimation. So in that, what the laboratory has to do is they have to treat the specimen with blocking reagents and then reperform the test. So in hook effect, there is high concentration of calcitonin which interferes. So then we have to dilute the sample. This problem we see especially in metastatic MTC. You might have seen reports more than certain number, more than 20,000, more than 10,000. So it becomes important because when we have a patient who has say more than 20,000 report, we are giving say a TKI to the patient, that is tyrosine kinase inhibitor. Patient comes back after 3 months. Now we want to know how much the response has been. If again the report says more than 20,000, we are at loss, like whether there is a response or not. Of course, one can do imaging, but for biochemical response, it's important that you know the exact number. And for that, I think it's important to dilute the samples and test again. And there is also something called as macrocalcitonin, which is falsely elevated due to high molecular weight aggregates. So in this, one has to perform serum precipitation with polyethylene glycol. So don't get overwhelmed with this. Just remember these 3 words and roughly what they mean, what is their importance. So as I mentioned, CEA is produced from malignant C cells, and it is also prognostically important. As far as ultrasound is concerned, there is no specific differentiating feature between MTC and other thyroid cancers. So TYRETS is what is used, but I would like to mention here that the data, the classification criteria using ultrasound are skewed towards classifying PTC rather than MTC, of course, because of its rarity. Now coming to FNAC, FNAC is of course the gold standard for diagnosis of all thyroid cancers. Sensitivity is about 89 to 98% for follicular thyroid, papillary thyroid cancers, whereas it is only 57% for MTC. So recent studies have, I mean, because of experience, there is a reporting of increased sensitivity, but specificity is again very less for on FNAC for MTC. So then it depends upon the clinician to interpret the reports and go with the further management. So whenever you feel that a young patient is coming with a relatively small nodule in the thyroid with bilateral neck nodes, especially of course if there is a family history or any suspicion, then one has, even though the report doesn't say it is MTC, one has to suspect MTC and then do biochemical testing. So what are the classical features on cytology? The smears are typically cellular. So the main important thing is loosely cohesive cells. They are apart from each other. The cell's shape can be epithelioid, spindle shaped, plasmacytoid, that is round, and polygonal with eccentrically placed round nucleus. So coarse granular chromatin, azurophilic granules. If you go back and read this, the cytology reports of our patients reported at SGPJ, you can see these, they describe all these things. And there is sometimes background amyloid depending on whether that particular specimen had taken it or not. And you will also see that there is binucleated, multinucleated cells present in this FNAC. So if these features are seen, then obviously if amyloid or if we are seeing this binucleated cells and loosely cohesive spindle shaped cells, then obviously the diagnosis is straightforward. But even then you have to confirm it with if you want, you can also do immunocytochemistry for calcitonin, and of course you're going to do serum estimation, biochemical estimation. Just remember that even medullary thyroid cancer can have variations. There are so many names, no need to remember all this, but these are very, very uncommon. And especially during my study, I have observed in SGPJ that we had at least 5 cases of sporadic MTC which co-occurred with papillary thyroid cancer. So they can even co-occur with other thyroid cancers. So on FNAC, micro MTC will not have classic features, and MTC can have follicular pattern. That means it just resembles some cluster of cells, microfollicular pattern, like how the follicular thyroid cancer appears. And rarely Hurthle cell neoplasms can have discohesive cells. So if you see other thyroid cancers, papillary has papillary pattern with certain nuclear features, and FTC, that is follicular thyroid cancer, has microfollicles, and Hurthle cells have Hurthle cells features. But they are all cohesive cells, cohesive group of cells. Discohesion is considered to be one of the features of MTC, whereas certain Hurthle cell neoplasms can have hypercellular discohesive plasmacytoid cells with granular cytoplasm. That is when, then again, of course, biochemical testing and other features would help. So amyloid is not consistent. It can be seen in up to 80% of FNACs. But how do pathologists differentiate between colloid and amyloid? So on in a slide, if there is a cracking, that is most probably colloid. Generally, amyloid will not crack, and you're seeing homogeneous pink stained areas with the other features that I described. So again, Congo red staining is used in histopathology for amyloid. I just mentioned here so that we won't forget it. Remember, and one of the slides we have in our exam has this slide of MTC with Congo red staining. So make sure that you, I mean, it's like a spotter. If you see it, it is MTC. So one has to remember that. So nuclear grooves are not a feature of MTC, and other things are non-specific, like we can skip it. So recently, the FNA samples, if there is a confusion, can also go for washout studies for estimation of calcitonin. And that can even be done from lymph nodes also, whether there is a metastasis in a certain lymph node, enlarged lymph node or not. And another test that can be done on FNA samples is genetic testing. But the cost effectiveness and the real effectiveness of these things for diagnosis of MTC is definitely questionable, whereas these are robust for PTC and follicular derived thyroid cancers. So additional imaging may be required to assess the extent of local disease and for detection of other components of hereditary MTC that we will see in a while. Generally, we prefer CECT neck and chest to estimate local extent. And if the most common site for metastasis for MTC is liver, so if needed, then 3-phase contrast enhanced CT of the abdomen can also be done. And bone scan is to be performed if we are suspecting bone metastasis, especially if there is suspicion and if the calcitonin level is more than 500 picogram per ml. PET-CT is not routinely recommended. As we are seeing these days, the trend is to perform PET-CT for every cancer. But routinely, it is not recommended in a case of MTC unless there is a need to perform. Even if we have to do FDG PET is not recommended. Only it is useful only if the tumor is suspected to be very dedifferentiated. Like if the calcitonin is very less and if there is a high rise in CEA, then only we have to go for FDG PET. But otherwise, if one has to do a PET scan, that is generally done with gallium DOTATOC, these kind of scans. And because they lodge somatostatin receptors 2, 3, and 5. And of course, we can also see adrenal masses in these cross-sectional imagings. So one has to keep in mind that particular thing also. So RET proto-oncogene and its importance. It is important for both hereditary and sporadic MTC. Germline mutation in RET proto-oncogene is seen in hereditary. It is located on 10th chromosome of human genome. It encodes a single pass transmembrane receptor of tyrosine kinase family. We all have heard so many, the most common transmembrane receptors are 7 pass. There are few 5 pass, but this is a very simple single pass transmembrane receptor of tyrosine kinase family. And the mutation that we will see in this proto-oncogene is a gain of function mutation. This is favorite question of Amit sir, and it's important because even a single point mutation can cause gain of function, and this gets activated constitutively. So germline RET mutation, this we have seen. Somatic mutation is seen in sporadic MTC. So now classification of so inherited MTC is nothing but MEN2, that is multiple endocrine neoplasia type 2. Here you have to understand that there are only 2 types, 2A and 2B. All the FMTC and that is familiar MTC and other subtypes are all part of type 2A, as we can see here. So MEN type 2A has classical, that is which includes MTC, FIO and PHPT. MEN2A with CLA, that is cutaneous lichen amyloidosis. MEN2A with Hirschsprung's and familial MTC. They all come under type 2A as of today. And the second type is type 2B, which has MTC, FIO and other features, which I will elaborate later. So this is an autosomal dominant, both of them are autosomal dominant, and they have very high penetrance for MTC. Hereditary MTC is seen to be bilateral and multicentric in the thyroid. For a given stage of disease, I mean, if you exclude men to be, for a given stage of disease, prognosis of inherited MTC is better than sporadic MTC. I hope I'm clear. So if we compare sporadic MTC and inherited MTC, the prognosis is in general favorable for inherited type of MTC than for sporadic. So the clinical presentation and manifestations are same, whether it is meant to associated or sporadic. Just the age and the centricity, multicentricity, bilaterality, these are different. But for a given stage, it is seen to be better for sporadic, for inherited. I think probably because sporadic MTC have mutations mostly in exon 16 918 codon. So please don't get confused here. I'm going to come to this point in the further slides. So if you get I think you may get a long question for structure and function of RET gene, because so much is of the treatment of MTC and even the RET rearrangements of PTC. So one needs to understand the structure of RET. So the product of RET gene is a receptor tyrosine kinase. It promotes growth and differentiation signals in tissues that are derived from neural crest, and of course there are many other cells from endoderm also. So predominantly C cells of thyroid gland, adrenal medulla neurons, and other tissues. It has 4 natural ligands, that is glial cell derived neurotropic factor, TNT, artemin, and percephin. These are the natural ligands. So whenever these natural ligands come on this receptor, as we can see here. So this is one red protein, this is another red protein. They are side by side. And if a natural ligand comes, they dimerize like this. So this is the extracellular part. This is this violet color one, and the yellow one are the extracellular part. The blue one is transmembrane, and the red part is the intracellular part, which are tyrosine kinases. Okay, so when there is a ligand, they dimerize. When they dimerize, then the tyrosine kinases get activated, and then further signaling is activated. So one has to remember, you can just draw a very simple diagram of this. Extracellular part, most important, is there is cysteine rich domain, which has 5 cysteine residues, and a single transmembrane domain, and 2 intracellular tyrosine kinase domains. So you can just draw this picture, and you can show that there are 2 receptors side by side. And once a ligand comes, of course, there's a need for co-receptor also. They all together become dimerized and then function. So cysteine-rich regions are the most common site for mutations. Majority of the MEN2A. MEN2A is, of course, more common than MEN2B. We all know that. MEN2B is very rare. In fact, less than 5% is MEN2B of hereditary MTC. And even in MEN2A, mutations of these cysteine regions is the most common one. So what are all these cysteine regions coded by? So exons 10 and 11. I'll show you that diagram later. So exons 10 and 11, that is codon 609. One has to know these numbers also, because we deal so much with MTC and hereditary MTC. It's important that you, at least once you see the number, you can approximately place it in one exon. 634, of course, we all know it's in exon 11. And before that, obviously, it should be in exon 10. So ligand independent dimer. So mutations in this cysteine-rich region, one of the 5 residues of cysteine, if they get changed, what happens is there is no need for ligand to come for these receptors to dimerize, but still they will dimerize. Okay, so when there is this mutation, all the receptors dimerize automatically and activate the downstream pathways. And mutation in 634 is associated with PHPT and pheochromocytoma also, and is the most common genetic defect. Coming to intracellular tyrosine kinase domains. So here, there is no dimerization if there is a mutation. Just even a single receptor without dimerization also, without ligand also, it can activate its downstream tyrosine kinases. So this is seen in exon 13, 14, 15. And these are mainly in tyrosine kinase 1 domain and predominantly seen in familial MTC. They account only for minority of the cases. And here one important point is, again, 804, codon 804 is also intracellular tyrosine kinase 1 mutation. And it is a gatekeeper mutation. And with this mutation, there is decreased sensitivity for RET targeting multikinase inhibitors. Okay. So coming to intracellular domain, that is tyrosine kinase 2, MEN2B is coming from mutation in this area of that is exon 16 918 mutation. Okay, here more than 50% of MEN2B cases are seen in as de novo germline mutations. We know that it is fatal and MTC develops early, and mostly the patient doesn't even reach the adult stage to marry and to reproduce. I mean, for those kind of reasons, generally 50% of the cases are de novo. And not only 918, we all know 918, other mutations like A883F have been seen in MEN2B kindreds rarely, and dual mutations, dual tandem, that means side by side codons mutations like in 804, 806, 804, 904, together if they occur. Suppose the patient has mutations in 2 codons, then also a severe form, which is similar to MEN2B, atypical MEN2B is seen. Okay, so mainly 918 and other things are 883F, but this is very, very rare. And if there are dual mutations. So as we can see here in this 634, there is no ligand, there is no need for co-receptor, but still they can dimerize and function. Whereas in 918, they're just like that active. They don't need anything, just the receptor because the mutation is active. So this is the, if you want to understand, we can see that from exon 10 and 11 onwards, the mutations become relevant. So generally 10 and 11 MEN2A, and 13, 14, 15 is MEN2A, which is again familial MTC is also MEN2A, but mostly FMTC is in these zones. And MEN2B, of course, is in 16. Somatic mutations are seen in about 65% of sporadic, and the codon we have to remember is 918, that is exon 16. We have seen here that if there is a germline mutation in 918, severe form of MEN occurs, which is MEN2B. But in sporadic MTC, this is the most common somatic mutation. That is the reason probably the disease in sporadic is, for a given stage, is more severe for sporadic than inherited. So in a mutually exclusive fashion, that means if there is no RET mutation, RAS mutations are seen in about 20 to 25% of sporadic cases. So of course, we all know that it's present only in the tumor cells, but not in the other tissues, and it's not transmitted. So if one asks, what are the mutations in somatic RET mutations that are seen? Generally, it is in exon 16, 918, about 60% of somatically mutated, RET mutated tumors. Others that are seen are 630, 634, like we seen inherited, and then 609, 620, 891. So the numbers are pretty much the codon numbers are the same, but you understand, I think, the difference between the frequency. So again, even in this sporadic also, the stage of the disease, the prognosis have been seen to be affected by the codon that is affected in sporadic MTC also. So we all know that we commonly hear genotype-phenotype correlation in MTC. So what is the most important implication is, if we understand that this particular form of MTC starts so early in the life, then we can intervene in that particular individual even before the disease develops. So we can decide the age of prophylactic surgery. So surgical outcomes and survival depend on the stage and pathological features in all genotypes. So early diagnosis by screening of at-risk family members is essential, because MTC is at the end of the day life-threatening, and if we do a surgery, it is patient can live his life, his or her life. So that is the importance of knowing all this. So we all have to remember this ATA categorization, which was ABCD in the past, and 2015 ATA guidelines onwards, they have categorized D as highest, C as high, A and B as moderate. So these are the red codons 918, 634, 883F, which we have seen rarely can cause men to be. It is still placed in high risk only because that's a rare thing. And rest all fall into the most common 634 is in high risk, and rest all fall into moderate risk. And so recommended age for thyroidectomy is for the highest in the first few months of life, less than 1 year. For high risk mutations, less than 5 years. And for moderate risk, screening should start at about 5 years of age, and thyroidectomy prophylactic surgery can be planned individual basis. So this is the basis why this age has been decided like that. So coming to screening, once a germline mutation is identified in an index case, the mutation analysis has to be performed in the first and second degree family members. So genetic counseling and testing. So whenever you're telling genetic testing, it is accepted. It is assumed that genetic counseling must be done. Without counseling, there is no just plain genetic testing in medical science. So it has to be performed in all MTC patients, first degree relatives of patients with proven RET mutation, parents of infants who have clinical features probably of meant to be. Like if you have noticed the child has Hirschsprung's disease or large tongue or Maffnod habitus or whatever, if you notice that meant to be other features are present, then also one has to think of MEN and test for RET mutation. Patients who present with cutaneous lichen amyloidosis, because CLA presents earlier than MTC in these patients, or the infants who are seen to have Hirschsprung's disease. So prophylactic thyroidectomy is only total thyroidectomy unless it is 918 mutated, or if there is no evidence of disease, but the calcitonin has been found to be more than 40. That means there is probably C-cell hyperplasia or micro-MTC, which is not seen on imaging. And it is important that these surgeries in the infants or children are performed by experienced endocrine surgeons, because the identification of nerves and parathyroids is very tricky. So coming to briefly about pheochromocytoma in MEN2, about 40% of the patients with MEN2A and approximately 50% of MEN2B have pheochromocytoma. It is there is again a continuum from adrenal medullary hyperplasia to pheochromocytoma. It tends to be bilateral in about 30 to 40%, and extra adrenal pheochromocytoma is rare, but it has been seen to occur, and malignancy has not been reported, and there are interfamilial variations even for a given mutation, and there's a large variability of penetrance. So estimation of metanephrines and imaging, as you do for sporadic pheochromocytoma, is what is applicable here. PHPT is seen in 10 to 25% of the patients, and it's multiglandular disease, and generally it is clinically occult. So this is favorite question of Sabha sir. What is the difference between PHPT of MEN1 and MEN2? MEN2, generally it is very occult, and even if you see PTH just slightly elevated, like in the range of 14, if in picomole per liter, just about 10 and less than 20. If you see for MEN1, they are so high, like tens of times elevated, and the disease is also more symptomatic. So we will test with serum calcium and intact parathormone. So reproductive options for patients with RET mutation, they should be counseled that prenatal testing and pre-implantation testings are available. Prenatal testing is performed in first and second trimester. If it is first trimester, chorionic villus sampling, obviously. And then second trimester, since amniotic fluid is formed, it is easy, just pick up amniotic fluid and then test on those cells. So if we know diagnosis pre-implantation in IVF, then we can select those embryos which are RET mutation negative. Even there are ways reproductive options available to prospective parents that, of course, one has to individualize. So coming to variants of MEN2, classical MEN2 is the most common variant, and frequency of development of MTC is mostly around 90 to 95%. PO and PHPT again depends on the specific RET mutation, and the most common codon leading to classical MEN2 is 634. MEN2 with CLA, as we can see here, this is cutaneous lichen amyloidosis. This is mostly seen in interscapular area. This is because of amyloid deposition, and it's itchy, papular, scaly, pigmented rash. Okay, this is seen before even the MTC is detected in many cases. This is again seen in codon 634 mutations. And of course, because 634 has other seem to have other things like FIO and PHPT, one has to evaluate these patients for that. But rarely even codon 804 has been seen to have this feature. So MN2 with Hirschsprung's. What is Hirschsprung's? This is aganglionic megacolon. That means because there is some disorder in the ganglionic cells, because of RET mutation, they fail to migrate completely, and the last part of the intestine will not receive these ganglions. So it doesn't relax. It doesn't relax as much. So there is passive accumulation of feces, a meconium, whatever, and so it enlarges, and there is functional obstruction. So at least 8 genetic mutations have been identified in patients with Hirschsprung's disease, but most common is RET mutation. So it is given that if there is Hirschsprung disease or aganglionic megacolon in a child, first test that we are going to do is RET mutation. What test are we going to do? Is a suction rectal biopsy. This is also a favorite question of the examiners. And in the biopsy, what are we going to see is are hypertrophic nerves in the myenteric plexus, but there are no ganglion cells that we generally see. So prevalence of Hirschsprung disease in men is only 7.5%, and codons are these 609 to 620. So it obviously it presents at a younger age. So it's the first presentation in these patients, and MTC, FIO, and parathyroid again depend upon what kind of mutation the patient is lodging. So coming to FMTC, the difference is that there is no FIO and PHPT in these patients, but the MTC behaves like in classical men 2A. It has been seen like this is also known in men 1, right? All of us have seen familial isolated hyperparathyroidism, which later, if we observe a few generations, then somebody will start developing some pituitary or some other feature, then we reclassify it as MEN1. Similarly, here, FMTC, it has been seen that over a few generations, it has been seen that some of them become men 2A because they either develop FIO or PHPT or something like that, or there are families with just FMTC also. So why it happens, we don't know, because if FMTC men 2A can have similar identical RET mutations. The criteria to call it FMTC is more than 10 carriers are detected in the kindred with the mutation and only MTC. And multiple carriers or affected members are above the age, because younger age, if they are dying before 50, that means probably there is some unknown element of FIO or whatever. So that's why we have to keep this in mind. And of course, detailed history and examination is to be performed before labeling it as FMTC, because then we are assuming that there won't be FIO and PHPT in these patients. Men 2B is seen 6% of all men 2, and but there is no PHPT in this, only MTC and FIO. Other features are mucosal neuromas, typically involving the lips and tongue. So if you go back to the records of SGPJ, we have 2 patients. The photos are quite famous, and then you can see, if you see those pictures, then you will remember these patients. They have intestinal ganglioneuromas and marfanoid habitus, myelinated corneal nerves. Myelinated corneal nerves is also very important. So MTC is the most common component of men 2B, and it is very aggressive, earliest onset amongst all hereditary ones. So treatment depends upon the stage. So the surgery is the most important treatment. If it is operable, if there are no systemic metastasis, then extensive meticulous surgical resection. The first surgery is the best surgery for these patients and has to be done by a trained endocrine surgeon, high volume endocrine surgeon, because this is unlike PTC. We don't have any other targets because we can't give radioactive iodine, nor we can suppress it with TSH. So it's very important that the surgery be done well. And if needed, local resections can also be done. There's a very limited role of radiotherapy also. That means we don't have many options. So we have to then depend upon the surgery. So the surgery, what surgery has to be done? In a case of proven MTC, the minimum surgery that is required is total thyroidectomy and central neck dissection. So lateral node management is controversial, but what we follow at SGPJ is what we follow in general is unless if on frozen section, if there is a metastasis, then we will go ahead and do lateral neck dissection. So the ATA says one can consider depending upon the clinical radiological evidence. It's not a must. Okay, but some groups like from Heidelberg and Essen in Germany have studied the levels of calcitonin, and they've seen that for them to achieve a decent biochemical cure, they have devised a particular method of the guidelines for surgery. If the calcitonin is more than 20 preoperatively, then doing ipsilateral central and lateral neck dissection achieves good biochemical cure, at least 50% biochemical cure. If there is more than 50, then contralateral central neck should be done. And if it's more than 200, then contralateral lateral neck should be done. If it's more than 500, of course, one has to be clear about absence of metastasis, but upper mediastinum dissection also needs to be done. And I mean, one has to put together all the imaging findings and then decide. So they've seen that in this study, at least 50% of the patients achieved biochemical cure when the calcitonin was less than 1,000. And if it is more than 10,000, probably it is metastatic already, and we are not able to see probably on the imaging. And these are very unlikely to achieve any biochemical cure. This approach has prevented a lot of reoperations in this study. And there are some sonographic predictors, according to some studies. They have seen that lymph node metastasis on preoperative ultrasound have been seen if the tumor size is more than 1.5 centimeters. That means if there are no preoperative sonographic evidence of metastasis, but if the tumor is more than 1.5 centimeters, irregular margins or subcapsular location, extrathecal extension, then obviously there is increased risk for lateral nodes. And if the preoperative calcitonin levels are more than 65, then also there is increased risk. Even SNB has been tried in MTC. We all know Dr. Nada Santrak. She's a good friend. And she has done a study on methylene blue, using methylene blue as for lateral neck dissection in MTC. And Pusini et al. Is also a very well-known group interested in MTC. They have studied with radiolabeled dye. So, I mean, these are just studies they're not into the guidelines yet. So this I've already mentioned. And coming to follow-up and outcomes, after thyroidectomy, physical examination has to be done, I mean, at 3 months and followed by 6 months, depending on what the findings that you're seeing in the initial follow-up. So physical exam and ultrasound, compared to PTC, one has to be more like aggressive in following up these patients and measure, apart from ultrasound, measure calcitonin, CEA, TFTs, and TSH 3 monthly, then 6 monthly, and 12 monthly. If calcitonin is more than 150, then probably there are metastasis. Then do imaging. If imaging is positive, then I will tell what to do and in the coming slides. If imaging is negative, then you keep the patient under follow-up and repeat the tests soon. So if it is detectable but less than 150, and there is no evidence of any recurrence in the neck on ultrasound or physical exam, then again follow up the patient. So these are very logical. These guidelines are very, very logical, nothing that you won't be able to answer. So PET scans are considered only when the calcitonin is higher than 500 to 1000. And as we have seen, DOTA tracers are preferred, but not FDG unless there is dedifferentiation suspected. Biochemical cure is seen only in 30 to 40% of patients, even if the stage, the surgery has been done perfectly, and if there is no reason why it should not come back to normal. So we don't know the reason for that, but cure is seen only in 30 to 40% of the patients, especially if it is node negative, it is higher, 83 to 95%. And if it is node positive, 21 to 32% will achieve biochemical cure. Post-operative normalization predicts survival rate of 97.7 at 10 years. So nearly 100%. So about 5% of the 3.3% of MTC patients who have initial biochemical remission, that means immediately after post-op within 3 to 6 months, the calcitonin is normal, but again, patient is seen to have elevated calcitonin in few years. So that is seen in about 5% of the patients. This generally occurs within like 1 to 7.5 years. What is long-term biochemical cure? It is defined as undetectable basal serum calcitonin. See, basal is different from baseline. Basal calcitonin is unstimulated calcitonin. Baseline is preoperative one. That has to be remembered. And undetectable basal calcitonin at last biochemical follow-up is defined as long-term biochemical cure. And it has been seen that if there are more than 4 lymph node metastases, biochemical cure is unlikely. Not that they have some residual disease, we do not know, but it has been seen like that. And if the preoperative calcitonin is more than 500, then also cure is unlikely. And at certain institutes in France, they follow this, that if there is more than 500 calcitonin, then they perform selective venous catheterization, and they try to detect occult metastasis, especially in the liver, because as we have seen, that's the most common site. The 10-year survival in overall in MTC is about 75%, but if it is locally advanced or metastasis, then it decreases to less than 40%. So coming to the most latest topic in MTC, that is metastatic MTC. It's incurable. So obviously the goals of treatment are to stabilize the disease and delay the progression, to provide loco-regional disease control if it is threatening a particular, suppose it is life-threatening, the palliation of symptoms of hormonal excess such as diarrhea, which is seen in metastatic MTC, or Cushing syndrome, because there could be ectopic ACTH production from the MTC, and to palliate symptomatic metastasis such as pain or bone fracture. As we have seen, that threatened life also needs to be taken care of. So if a patient has possibility of distant metastasis, elevated serum calcitonin or CEA, but no radiologically detectable mets, then no need to give any systemic therapy in these patients, even if there is rapid doubling time, because I will tell you why. Because then again, if elevated serum calcitonin with which is needing extensive reoperation, for example, the calcitonin is very high, say more than 1000 or 1500, and patient is having detectable local disease, and suppose I need to resect the trachea or do some extensive esophageal resection or something like that, or probably RLN, then you're suspecting there could be involvement of RLN, then it's imperative that I exclude occult metastasis before going for such extensive surgeries. So in those cases, if the routine imaging doesn't detect mets, then some groups have performed open or laparoscopic evaluation of liver, then taking biopsies, or doing selective venous catheterization and measurement of hepatic versus peripheral vein calcitonin levels to exclude liver metastasis before the surgery. So if in this procedure, if I find that the levels are high in the liver, that means there are mets in the liver which are not seen on imaging, and then I would not contemplate on avoidable surgeries, extensive surgeries in the neck. So palliative therapy, including surgery, radiation, and systemic therapy, should be considered in patients with metastasis which are symptomatic, like causing pain or mechanical compressions or signs and symptoms of hormonal excess. Diarrhea can be controlled with generally, of course, first you start with anti-motility drugs like loperamide, but somatostatin analogs like octreotide are more effective. So the question is, the diarrhea in MTC is hyposecretory, which is calcitonin mediated, but there is also increased motility component, but that's why it responds more to octreotide, because it's hyposecretory. And Cushing's can be treated with ketoconazole, like the Cushing's that we generally treat for adrenal causes. And liver mets are seen in about 45% of the patients. So I'll finish in another 5 minutes. If there are large isolated liver mets, then surgical resection can be done, isolated mets, without any other mets. And if it is disseminated and causing symptoms less than 3 centimeter size, then chemoembolization is an option. Of course, systemic therapy is also indicated in certain situations. Same principles go for lung and mediastinal masses. If there are peripheral and small lung mets, remember that we can do radiofrequency ablation. And for progressive and multiple mets, systemic therapy is an option. Spine and bone, spinal cord compression is an emergency. One has to treat with glucocorticoid therapy and surgical decompression. If they're not candidates for surgery, then radiation, of course, has to be given. And fractures or impending fractures need surgery or thermoablation, cement injection and radiation. So drugs like denosumab and bisphosphonates are recommended for painful mets. So brain mets are very rare, and if they are seen, then they can be, if they are isolated, they can be resected or subjected to stereotactic radiosurgery. And whole brain arteries, there are multiple mets. Systemic therapy should be very given in a very balanced way, because the drugs that are available are very extremely toxic, as in they cause a lot of adverse effects, but the efficacy is limited. And given the fact that MTC has very relatively slow rates of progression compared to other cancers, and the quality of life that the patient has currently versus what we are expecting by treating the patients with systemic therapy has to be weighed, and we have to keep in mind the performance status of the patient. So what are the options that we have for systemic therapy? See, coming from the last, cytotoxics is not an option. It's a last option. In MTC, it is not effective. Immunotherapy and tumor vaccines are still investigational. Peptide receptor radionuclide therapy using lutetium octreotide and indium DTPA octreotide scans, these are all again not robust, but we have done at SGPJ, and they have about response rates of about 15 to 20%, not more than that. So the only dependable options for systemic therapy in this group of patients is tyrosine kinase inhibitors. They are cytostatic, but not predominantly, they are cytostatic, not cytotoxic. So it's a simple mutational burden, which is RET receptor. And these molecules, these are small molecules, TKIs, they go and block these mutated receptors. So mechanism is that RET mutation, we have seen it activates the downstream pathways. So TKIs block kinase activity by competitive inhibition of with ATP for binding in the ATP binding pocket of the tyrosine kinases. So then they directly inhibit the activation of the receptor and further tumor proliferation, angiogenesis, invasion, metastasis. So phase 3 trials in MTC have shown that these TKIs are effective, cause considerable improvements in, mind you, only progression-free survival, not overall survival. So there are two subtypes of TKIs. One is anti-angiogenic multi-kinase inhibitors, which are non-selective, which act on multiple types of tyrosine kinase receptors like VEGF, EGF, FGF, and RET. The examples are vandatinib, cabozantinib mainly, and of course sorafenib also. Remember, vandatinib, VEGFR, and RET and EGFR, Zeta trial. It's a randomized phase 3 trial. Dose is 300 milligram per day, oral OD, and PFS is 30.5 versus 19.3 against placebo, but no overall survival difference. Diarrhea, hypertension, QT prolongation. These are the most common important side effects. Cabozantinib is exam trial, 140 mg per day, and 11.2 versus 4 months. This is also a randomized phase 3 trial. Again, there is overall survival benefit, but not statistically significant with cabozantinib. So sorafenib, there are only pilot studies in MTC. It's just a second and third option drug, and all the drugs that cause VEGFR which act through VEGFR receptor cause hypertension. Most importantly, with sorafenib, there is hand-foot syndrome, and so we generally tend to give pyridoxine 40 mg OD or BD for these patients. So this is how VEGFR acts on the blood vessels of the thyroid as well as within the thyroid cells. So next are mutation selective kinase inhibitors, that is RET targeted inhibitors. The two FDA approved ones are selpercatinib and pralsetinib. Okay, so there are studies, robust studies, but not randomized studies for selpercatinib, and they are obviously, they target the RET tissue, but some of them may not adequately inhibit the other signaling pathways that these receptors escape. So that is one disadvantage with them. They are thought to have fewer side effects, but as the studies have shown that they also have limiting side effects in many patients. And resistant clone, if develops for RET targeted, then it becomes a disadvantage when compared to multi-kinase inhibitors. So selpercatinib is FDA approved in the last year in 2021, and the trial is Libretto, which is still ongoing, but they have done interim analysis and then they got pre-approval. The dose is 160 milligrams. Hypertension is a very significant side effect, and QT prolongation is also very concerning for these patients. Prolixatinib is also FDA approved. It's an open label. These two are open label, that is non-randomized studies. Arrow trial, which is also ongoing. The dose is 400 mg OD, and again, side effects are similar. Another ongoing trial is on neoadjuvant, pre-operative administration of selpercatinib in advanced and locally advanced RET-altered thyroid cancers. So obviously we can give these two drugs if there is reputation only, either somatic or inherited. So this is going on in MD Anderson, and the current research focus is on genetics, epigenetics of MTC and targeted therapy. So then again, one of the questions that generally we face in the exams is, what are the publications from India and especially from your institute? The ones that I have come up with are the ones that from recently published in 2021 on hereditary MTC. Again, we have a very extensive observational study published in 2011. Then there are about, again, the last three are observational studies published from CMC Vellore, and first two are from SGPJ. There are few other studies which are predominantly on genetics, laboratory-based studies from Reliance Labs. So I think one has to go through all those things for understanding the profile of what is the research of MTC from India. That's all from my side.